Okay, neurological emergencies. Most neurological emergencies are going to cause altered mental status of some sort, which makes them quite a bit of fun. A coma, by definition, is a state of unconsciousness from which patient cannot be aroused by verbal or painful stimulation. Okay? Unconsciousness in all patients equals an immediate life threat because they have the potential for a loss of airway and aspiration. And we've covered those, I think, enough times. You guys know everything with that. So anybody who's in a coma, management of ABCs must come before investigation of the actual cause. So what we just talked about with AEIOU tips is our investigation of why someone's in a coma and what can we do about it, or why are they unresponsive. However, before we really start going through that line, we've got to establish an airway and make sure the ABCs are secure. Okay, so airway, open, clear, maintain. You may have to suction, head tilt, chin lift in non-traumatic patients, modified jaw thrust in trauma patients, immediately control C-spine. Breathing, assess presence or adequacy. High flow 2 immediately on all patients with decreased LOC. So on most of the patients we've talked about, we've said, well, make sure it's at least 94%, right? Not if they're altered. Okay, if they're altered, we're going to assume that something is causing the brain to be starved of oxygen, and we're going to provide high flow oxygen. Assist respiratory rate, tidal volume if inadequate. Circulation, do they have pulses, and what level is their perfusion? Because remember, pulses do not necessarily indicate that they are perfusing adequately. Radial pulse, blood pressure of 80, carotid, blood pressure of 60. Really need to pay attention to cap refill, that type of thing. After ABCs are stabilized, quickly investigate the cause. Okay. D, depth of coma. What does the patient respond to, if anything? So just because they're unresponsive to alert, verbal, they may still moan to pain or something, and that could be an indication of there's something still going on. And how do they respond? So depth of coma. Eyes, pupils, are they equal, dilated, or constricted? So responsive to light and how. Look at the pupils. They should be the same. They should respond the same, whatever they are. If they're ever unequal, we know that that equals a problem, right? If they're real constricted, what is that a sign of?
Narcotic overload.
Okay, narcotics. Good. And if they're dilated, would be stimulants, so methamphetamines, cocaine, that type of thing. What if one's dilated and one's constricted? Head injury. Okay, what if they're just sluggish or they react slowly?
Is that alcohol?
Alcohol will cause dilated pupils. It could also be sluggish, or it could also be head injury. Okay, respiratory pattern. Okay, again, we talked about with diabetics how they'll have Kussmaul respirations or rapid, deep breathing. That may be an indication to you right there when you're assessing the airway that, hey, this is Kussmaul breathing. I bet you this guy's hyperglycemic, right? But you're going to check the rate. Is it unusually deep or shallow, or is it altered? If their breathing is altered, that's a good indication that it's a head injury of some sort. Okay, if it's really absent or shallow, that's usually an overdose of some sort. Motor function, evidence of paralysis. Is there any movement on stimulation, and how do they move? Again, just to kind of gauge the level or the depth of the coma that they're in. Can anybody think of another tool that we could use to gauge the depth of the coma that they're in? What do we use on our trauma patients? GCS, yeah. So, this is going through this, what they call DERM. It's not my preferred method. I would just do a GCS on the patient and see where they're at. Okay. Vital signs, are they showing any signs and symptoms of shock? Are they showing any signs of increased ICP or any indication of heart arrhythmias? Okay. We all know the triad for ICP, right? hypertension, bradycardic, irregular respirations. Okay, and we've beat shock to death by now, right? Everybody can recognize shock. Okay, head-to-toe survey. Are there any injuries that may have caused the coma? That's what we're going to look for first. Are there injuries caused by a fall? Is there anything that the scene or the bystanders can tell us about what may have caused this patient to be unresponsive? Possible causes: not enough oxygen, not enough sugar, not enough blood flow to deliver the oxygen or sugar. Direct brain injury could be structural, such as trauma. Trauma could be metabolic, such as toxins, infections, or temperature. Okay, here you go. AEIOU tips. Okay, and again, I added a few of my own in there. Remember, so under E, environment, what would be some causes of the environment? It'd be heat and cold emergencies, right? Okay, you can have a heat stroke. You can go unconscious from hypothermia. They didn't include it on here. However, I see it all the time in the field, so I've added it. So alcohol, epilepsy, insulin would be diabetic problems. Overdose, it could be an overdose on everything. And you overdose in two ways. Does anybody know what they are? What are the two ways you overdose?
Are you talking like accidental overdose?
Sort of, yeah. What are the two ways you overdose? Define accidental overdose. Like, what are you thinking when you think accidental overdose?
Taking the wrong medication, maybe, or the wrong amount of medication.
Okay, and that occasionally happens. No, there's two basic ways you overdose. One is you take the medication as you're prescribed every day, but it's too much, and it eventually causes you to overdose. Say over a 3-week or a month-long period, you build up too much of the medication in your system, or you can take a whole bunch of medication all at once. So there's two basic ways. So whether it's accidental or on purpose, or you're taking somebody else's medication, you either do it slowly over a period of time because you're getting too much medication, or your metabolic system is changed in some way, such as the diabetic. He takes the same amount of insulin every day, but he forgot to eat, or he exercised too much, or whatever it is. Or you have somebody who wants to kill themselves and makes them a potassium brownie milkshake and eats it all at once. Okay? Uremia and other metabolic causes. So we talked about diabetes and insulin, okay, which is a hormone produced by the body. Well, other metabolic causes, can anybody think of what that may be? What does your body work off of, cellular-wise? Like what do you need in your body besides sugar and oxygen? You need, what's in Gatorade? Electrolytes. Okay, your body functions off of electrolytes such as sodium, potassium, calcium, magnesium. Any one of those can be too high or too low and can cause problems, specifically sodium. If you have hyponatremia or low sodium, it will put you into a coma. That will mimic a stroke. Okay? We in the field, we can't test for that. Okay? I can't look at, yeah, you're kind of salty today. Okay? Unfortunately, it doesn't work that way. And so there's a lot of times where we will have somebody coming from a nursing home or wherever it is, and they'll say, well, so-and-so collapsed on the floor and had a seizure. But they're breathing now, they have a blood pressure, they have a pulse. Okay, so there's nothing for us to do ABC-wise. We're going to check a sugar, we're going to maybe put them on a 12-lead, make sure their heart's okay. We're going to look at their history and say, well, I don't know. Well, wait, look, here on their history, it says they have a history of hyponatremia. Could be sodium. Okay, can't necessarily fix it right now. We can take them to the hospital. We can tell the doctor our suspicion. He's going to draw a full set of labs, and then he can treat accordingly. So there are other metabolic syndromes that we're going to run into that we're not going to be able to detect, and that's under this uremia. It's not just, insulin. Okay, it could be any of those other problems. Trauma, I think, is self-explanatory. What were the other two that I threw up here? Trauma, tumors, and toxins. Okay? There's generally what I say is any first-time seizure over the age of 30 is a brain tumor until proven otherwise. Okay? If it's not related to drugs, If they can say, nope, it's not any of my medications, I'm not doing any recreational drugs, I don't know why I had a seizure, it's a tumor till proven otherwise. And toxins, we kind of, it kind of goes under overdose, but it kind of, there's other ways that you can be. So when I'm thinking toxins, like there's overdose where it's like, okay, yeah, I took medication, okay. Well, we could all get hit with carbon monoxide poisoning right now by the furnace in the building going wrong and we not knowing it, right? And so we may have no clue that we're getting poisoned or whatever it is. And so you always got to kind of keep that window open that, your car could have a problem, your furnace in your home could have a problem, whatever it is, and it could cause you to go unresponsive.
Can you not smell carbon monoxide?
No, you can't. Colorless, odorless, tasteless. Infection, meningitis especially, but sepsis also from any sort of infection can lead to a coma. Psychiatric, obviously, again, this is altered mental status, not necessarily just coma. So psych people are kind of altered all the time. And then stroke, syncope. I think there's another one in the book besides stroke and syncope. Seizures. Yeah. Okay, management, secure the airway because the basic protective reflexes may be lost, and that's what we say. They've lost their ability to clear their own airway, such as gagging, vomiting, that type of thing. Immobilize spine unless absolutely certain injury may not be present. Okay. Spinal injury not suspected, put the patient in the recovery position on their left side. High flow O2, assist ventilation is needed. Monitor neurological vital signs every 5 minutes in the unresponsive patient. Okay, protect patient's eyes on long transports. You may just want to tape them shut or whatever you need to do. Most of the time they're going to be closed anyway. However, if they are open, you may want to close them. Some comatose patients, they may hear, understand, even though they're unable to respond. So we generally try to talk to them, explain to them what's going on. Hey, it's EMS. We're going to put you on a backboard. We're going to place you in our ambulance. We're taking good care of you. So treat, reassure accordingly. And some of my coworkers, they've treated people who were stroking out that have sent them cards, and in the cards have said, I really appreciate you holding my hand on the way to the hospital, even though I couldn't tell you. Okay. Seizures, episodes of uncoordinated electrical activity in the brain. So signs and symptoms depend on the area of the brain that are involved. There's a lot of people that have seizures because they are what we call epileptic. They have seizures. Other people who aren't epileptic can have seizures from anywhere from heat illnesses to drugs, alcohol, diabetics, trauma patients can have seizures if they hit their head. There's a lot of causes of seizures. Epilepsy is a tendency to have repeated episodes of seizure activity. Not generally, there's no identifiable reason to say why they're seizing. They just know that they are prone to having seizures. Seizure types. You guys need to know the different seizure types for your test. Okay? Grand mal would be tonic clonic seizures. That's where you have the rhythmic jerking of the arms and the legs. Patient will be unresponsive and apneic while this is occurring. Petit mal is what we call an absent seizure. It's where they're talking and then they resume mid-sentence and didn't even miss anything. Okay, it's an absent seizure. They just blank out and then they come right back where they were. Focal motor seizure, simple partial. That could be where it's just their hand is twitching. Okay, it's just whatever. And then what we call complex partial seizures, which could be more, Okay, review these, read the definitions of them in your book, because you're going to have patients on your test where you're going to need, it's going to list all 4 of these as the choice, and you're going to need to be able to identify which type of seizure the patient is experiencing.
So is psychomotor just like all extremities are shaking?
No, that's a grand mal. Psychomotor is more of where it interferes with their speech and it's I would be lying to you if I went into more detail than that. So read about it to make sure. But grand mal is the typical seizure you think of. Petit mal is the absence. Focal motor is where it's one certain body part. And psychomotor is where it, I'm trying to remember what exactly psychomotor is. Psychomotor, I believe, is where it interferes with their speech or their movement, and they do weird stuff. An aura is a sensation coming before a convulsion. So a lot of people who are epileptic, they know when they're going to have a seizure because they'll smell cotton candy. Anybody else smell cotton candy? Thud. Seizure. Okay? So, kind of cool. It's different for everybody. Patient may recognize a sign of impending seizure, may help locate origin of seizure in the brain. So they can go in and say, oh, was it light, was it smell, whatever, and they can try to trace to what region of the brain causes that. I had a girl, when I was doing A&P in college, I had a girl who had seizures, and she'd be like, I'm going to have a seizure, and we'd walk her out, and we had padded benches in the hallway, and we'd lay her on the bench, and she'd seize, and then we'd all go back to class. Okay, this will go through it more specifically, but I still want you guys to read about these in your book. Grand mal seizure, tonic, clonic. Generalized seizure affects the entire brain. Loss of consciousness. Tonic phase is rigidity, and the clonic phase is rhythmic jerking, incontinence, and ineffective breathing. So the rigidity that is what we call posturing. They'll get really tense. Sometimes they'll pull their arms in. Sometimes they'll put their arms out. But they'll tense up, and then they'll start shaking. Okay? And then they'll go into a postictal phase after the shaking, which is shaking could last any given amount of time. Most seizures, the tonic clonic phase lasts for a minute or two, and then they stop. Then they go postictal, where they'll just be unresponsive, and then they'll slowly regain consciousness. The big thing to worry about with these guys is they're going to have absent breathing while they're seizing. So you may need to try to ventilate them, but they may be clenched. You may not be able to. So at least try to put them on a non-rebreather, do what we can. But that's what we treat. So when they go into what we call status epilepticus, or a continual seizure, what we do is we start our IV on them. We sedate them so that their body stops jerking, and then we take over breathing for them. We can't actually stop the seizure, but we can stop the jerking. So we'll do that, and then we'll take over breathing for them so that we at least keep them alive, get them to the hospital, and the hospital can try to find the cause of the seizure and see if there's something they can do to stop it.
So the seizure will still be going on in their head?
Yep. The brain will still be having their electrical storm, even though we can stop the outward symptoms of it and get back to ventilating them. So postictal phase occurs after a generalized seizure. A seizure is like a 1-2 minute seizure is equivalent to running a marathon. Like, it burns up all of your sugar, and it will leave these people absolutely devastated, exhausted. They can strain muscles, pull muscles, tendons. They can dislocate shoulders and knees and cause trauma. That's why you want to kind of clear them, give them space. Don't let them grab onto anything. You got to really kind of watch them. So they're going to be exhausted when they wake up. They're going to have a headache. And they may even present with what we call hemiparesis, which is Todd's paralysis. It's paralysis of one side. So it almost mimics a stroke in that they may not be able to move their right arm or their right leg. So when we talk about strokes, if they've had a seizure, that may indicate that it's not a stroke. It could be Todd's paralysis. That Todd's paralysis usually lasts 24 hours. Petit Mal Seizure, no generalized motor spasm, loss of consciousness, appears to be staring into space, no loss of postural tone. So if they're standing, they're going to remain standing, but they're just out. And it may last for a few seconds, and they'll even resume mid-sentence exactly what they were doing. They were out for a little bit.
They won't have the postictal state?
Nope. They just resume right back right where they were. So they may have hundreds of absent seizures per hour. It's more common in children, and it's just whatever. Focal motor seizure, rhythmic jerking of limb or one side of the body, no loss of consciousness. So this is your hand just doing a constant twitch. Okay? And it can go on and on and on, and they just can't control it. And then psychomotor is loss of consciousness, but they do these weird automatisms where it's like they're sleepwalking or something. They're not there, but they're going to be awake and moving. Does that make sense? Okay, and this is why I was having a hard time explaining it to you, Blank, because it's not what we think of as a seizure. It's like a psych event, but they're not there. Does that make sense?
And who would have this?
People just have it. I mean, why are people epileptic? I don't know. It's seizure activity. They have seizure activity.
I don't really understand what you mean by this.
So, okay, so they could be, so I could be awake sitting here, and it may look like I'm having purposeful movement, but it's not. Such as I could be, I could be trying to snap my fingers, but I'm out. I'm gone.
Okay.
I'm seizing, and this is my
Got
seizure.
caught in emotion or something.
This is the point of my brain that's sending the seizure is telling my body to snap.
Okay.
Okay? So I'm out. I'm gone. I'm unconscious. I'm not going to respond to anything you do to me. I'm
Your
out.
eyes will be open and everything.
I'm going to be sitting here like this.
That's weird.
Okay? I may lose postural tone, but that part of my brain is sending a signal to snap. Or I may be a pianist and I may be playing. Or, heaven forbid, I played the trombone, so I may be... Okay? I mean, so it looks like, oh, they're just being crazy, or, you know, what are they doing? But they're out. They're gone.
Okay.
So maybe called in as drunk, OD'd, or a psych patient because they look crazy. But they're out. They're not there.
Would this be people with epilepsy also?
So epilepsy is a grand mal seizure. Okay. However, these people having recurrent psychomotor seizures is absolutely possible. Again, that's getting into neurology, and they probably have a billion terms for stuff that I don't know, and they may categorize this as epilepsy, and that just means that it's repeated seizures. And I don't know.
Okay.
For my way of thinking, epilepsy is recurrent grand mal seizures. Okay. So generalized seizure management during seizure, remove from potential harm, whatever that may be. Do not forcibly restrain. The big thing with seizures, you want to protect them, but you don't want to hurt them, as with any patient. So you want to clear obstacles away from them. Where it gets real dangerous for us is if they seize while they're on our stretcher, because we don't want them to fall off our stretcher. We don't want them to knock the stretcher over. The restraint belts, if they are pulling against them or their arms or their legs are locked, that can cause them to pull or dislocate things. So we actually want to loosen the belts, but we don't want to do that till we lower them to a point where if they fell off, they wouldn't injure themselves. So generally we'll lower the stretcher as low as it can go and then let them seize. If they're in the ambulance, we'll undo the buckles and then get ready to do them back up when the seizure stops. Roll them on their side. Avoid putting anything in their mouth. I think I told you guys about the med student that put a bath towel in this dude's mouth, and then the guy clenched. And so I got there, and I had to try to get a bath towel out of this patient, and he was clenched on it. So I couldn't breathe for him. I couldn't do anything because there was a bath towel in his mouth. And he said, well, I thought you were supposed to blow a... Well, whatever, dude. Okay, don't put anything in your mouth. And we eventually got it out, but it took us 2, 3, 4, 5 minutes to get the bath towel out of the guy's mouth. So, and he had a mouthful. Okay? So after the seizure ends, reassess ABCs. They usually start breathing on their own. They'll go through that postictal phase where they're altered and they'll slowly regain consciousness. What we can do to help them regain consciousness is usually high flow oxygen with a non-rebreather. As they regain consciousness, they will become combative because they're going to be really confused. They're not going to know where they are. They're not going to know who you are. They're not going to know what happened. They're not going to want anything on their face. They're going to go through kind of this combative phase. But they don't usually like get up and run. It's just they start pulling at things and moving things, and we keep talking to them and tell them what's going on. Hey, Acacia, you've had a seizure. Relax. You're with the ambulance. We're going to take good care of you. Acacia, you had a seizure. And as they get a little bit more, then they'll move into repetitive questioning where it's, I had a seizure? I had a seizure? I had a seizure? Are you seizing again? Okay, and they'll kind of go back through it. Anyway, most common cause of seizure deaths is postictal airway loss. So keep track of that. High flow to immediately assist breathing if ventilation is inadequate. Obtain history physical. And again, these people are altered, so we're going to go through our AEIOU tips, and we're going to try to figure out why they had a seizure. Yes, seizure can be a cause of altered mental status, such as it could just be that they're epileptic. But if they're not epileptic and they've never had a seizure before, we want to go through and find out why did they have a seizure today. Is there something I can do to prevent them from having another seizure, or is there something more life-threatening occurring, such as a heart arrhythmia, a stroke, a brain tumor, anything like that. So a trauma that could have caused or been caused by the seizure. Are they taking any anti-seizure medications that may indicate that they're on or that they are epileptic, such as Keppra or lithium? Neurovital signs every 5 minutes. If patient is ventilating adequately, transport on their left side with oxygen. Seizure, anything that injures the brain can cause seizures. So again, AEIOU tips. Just about any of those things can cause seizures on the list. And you're going to try to figure out which one it is. Do not assume seizures are due to idiopathic epilepsy until proven otherwise. Okay? So you're still going to check a blood sugar. You're still going to check them for alcohol or drug use. You're going to check for heat, cold. You're going to check for trauma. You're going to go through everything. Okay? Especially in the elderly. Like, it's one thing for a teenager because they still might be epileptic, and even in your 20s all the way up to 30, you could have idiopathic causes of seizures. After the age 30, there's usually a cause. Okay, and that's where the whole tumor thing comes in. If you're over 30 and you've never had a seizure before, it's usually drug or metabolic or a tumor or trauma. There's something causing the seizure. Status epilepticus is 2 or more seizures without intervening conscious period. So let's say I have a tonic-clonic rhythmic jerking phase and it lasts for a minute, and then it stops and I'm unconscious for the next 5 minutes, which 911, what is your emergency? Rachel's having a seizure in the classroom. Okay, we get in our truck, woo, 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 woo. We drive to here, and she's still unresponsive on the floor, and we witness her go into another seizure. And so we ask y'all, hey, did she come to in between this other seizure that had said no? She's been laying on the floor the whole time. Okay, that is status epilepticus. She's had 2 seizures without gaining consciousness. Okay, so what that tells us is that we are calling it 2 seizures. Okay, it was 2 rhythmic jerking periods. She may have been seizing the whole time, she just wasn't jerking. So at that point, we're thinking, okay, she's unconscious and she's not going to wake up on her own. We need to treat her. So this is an immediate life threat. Management, secure the airway, assist breathing with O2, transport, and request ALS intercept, because we need to, again, we need to give her medications and secure her airway. Syncope. So we get dispatched a lot for what we call multiple syncopal episodes. Okay, syncope basically means people passed out, but they regain consciousness. If they stay unconscious, then they're unconscious. Syncope means, it's temporary, and then they wake back up. So fainting, sudden temporary loss of consciousness caused by lack of blood flow to the brain. We know what causes syncope. It's lack of blood flow to the brain. What we don't know is what caused the lack of blood flow to the brain. Could be that they're having a heart attack. Could be that they're having a stroke. Could be that you stand up too quickly. Okay, that's all of you guys have gotten up off the couch or out of bed, stood up real quickly, got dizzy, sat back down. Right? You've all experienced that dizziness. Okay, that's syncope, or what we call near syncope. You stood up, you got dizzy, so you sat back down, the dizziness cleared, you're able to stand back up and go on your day. Well, the older you get, the harder it is for your body to compensate for that sudden change in your blood pressure by standing up so quickly. Okay? So the older they get, the more likely they are to actually pass out. So we do see syncope a lot. So causes of syncope could be stress, fright, or pain. Causes a vasovagal syncope, which the vagus nerve runs from your head down through your body. Okay, it controls, or it's the brakes to your heart, different things. We commonly see a vagal response on elderly patients who are constipated or straining real hard on the toilet. They trigger their vagus response, it slows their heart rate down, drops their blood pressure, and they pass out. I've picked up a whole lot of people off the floor. When that happens and they pass out, it causes epinephrine to dump. And so we'll get there and they'll be real cool, pale, diaphoretic, looks like they're having a massive heart attack, but everything stabilizes on its own. And they'll say, no, I never had chest pain. I just got real dizzy and passed out while I was trying to poop. Okay? Orthostatic hypotension, blood pressure fall on standing. That's what I was just describing. However, that could be an indication that they are hypovolemic or becoming hypovolemic, right? They're okay when they're sitting or laying down, but if they try to stand up, they get real dizzy and sick. Increased size of vascular space, again, they could be vasodilating. Well, I took my Viagra and I'm having syncopal episodes. Okay? Decreased cardiac output, again, it may be a heart attack or something occurring. Prolonged forceful coughing, someone who's real sick, this prolonged forceful coughing can also trigger a vasovagal syncope. Okay, management of syncope, ABCs, keep the patient supine, elevate lower extremities, apply oxygen, and assess for that underlying cause. Again, you're going to go through AEIOU tips, see if there's anything on there that could have caused it. And then it may have been the vasovagal response caused by any one of a million things. Okay? True syncope will correct itself, and they'll feel better, and they'll want to get up, and they'll say, hey, I'm just fine, there's no big deal, let's go. If you find a reversible cause, such as they're hypovolemic, then it's syncopal episode with hypovolemia, and that's something that goes to the hospital to be treated. If it's a vasovagal syncope, it'll correct itself. Okay, CVA, cerebral vascular accident, or a stroke. Damage of portion of the brain due to interruption of blood supply. Mechanisms, it could be a thrombosis, a hemorrhage, or an embolism. Thrombosis and an embolism block or cut off blood supply. A hemorrhage is bleeding in the brain. Typically, when we talk about it, it's just thrombosis and hemorrhage. Okay, thrombosis, blockage of vessel by a thrombus. A thrombus is a blood clot. Okay, usually forms an area narrowed by atherosclerosis. So same kind of mechanisms as a heart attack. You get a buildup of plaque and stuff in the arteries, and a blood clot gets caught in that artery in the brain. Typically in older people, frequently occurs during sleep. So they go to sleep, they don't wake up, type of thing, or they wake up and they have slurred speech and weakness on one side. Embolism, blood clots, plaque fragments travel through the vessel and lodge and block flow. So an embolism is just something that's free floating in the blood and blocks off something. Often associated with atherosclerosis of the carotid arteries. So the atherosclerosis is not necessarily in the brain, it's down here in their carotid arteries, and part of that plaque breaks free. Well, what happens? What does the carotid artery feed? It feeds the brain. So it breaks free in the carotid, and it goes up to the brain, and it gets stuck in a smaller artery. Okay? Chronic atrial fibrillation. Atrial fibrillation is a cardiac arrhythmia that basically the atrium are shaking, but the ventricles still fire. And since the atrium are just shaking, blood actually will clot while it's in the atrium getting sent round and round. It creates kind of just a whirlpool effect where the blood stays in the atrium for too long. Okay, and then eventually the atrium will contract. Something will happen that will move that clot through. It comes down to the ventricles and it gets pumped out the aorta, which then it goes and that clot's going to lodge somewhere. If it lodges in the brain, it's a stroke. If it lodges in the heart, it's a heart attack. If it lodges in the intestines, it's a ischemic bowel. If it lodges in your calf muscle, it's a DVT, deep vein thrombosis. Okay, it could go anywhere in the body. Okay, hemorrhage, vessel ruptures associated with hypertension, aneurysms of cerebral blood flow. So chronic hypertension leads to aneurysms, usually characterized by sudden onset, severe signs and symptoms. They will have the worst headache of their life. They may have initial loss of consciousness and then a return of loss of consciousness. Anywhere that free-floating blood contacts brain gray matter, it's necrotic. It kills it. Okay. So an ischemic stroke, you can see it's kind of all this area of dead tissue from where blood supply was blocked off, whereas a hemorrhagic stroke, the blood actually is in the folds and whatnot of the brain tissue. If this is a big enough bleed, it will cause ICP and the brain to shift. Depends on the size of the artery and the amount of pressure it can build up. So signs and symptoms, alteration in consciousness, so altered affect. What does affect mean? What's a patient or a person's affect? It's kind of your personality. Okay, it's kind of the way that you would normally behave or respond to people. And if there's a sudden or a noticeable change in what they do or in their activity level or what they would normally participate or be interested in. Confusion, they don't know where they are, they don't know what they're doing, they're forgetful, they're confused. Dizziness or coma. Localizing signs, if they are somewhat alert, you may see paralysis on one side or the other. Loss of sensation to an extremity. Loss of speech or slurred speech, unilateral blindness, meaning just one side of visual disturbances, loss of vision in half a visual field of both eyes could also be a cause. And then we're going to look for pupillary changes as signs of a stroke. Some signs or symptoms, some of this stuff can be very vague. Like I had a lady who was in her 40s. She was with her husband at home. Everything was fine and dandy. She was getting ready for the day, and it was taking her forever to get ready. So her husband went up to check on her. She was in her bedroom. She had gotten out of the shower. Her hair was still wet, but it was done up in a towel. However you girls do that, whatever. It was done up in a towel, but she was topless. She was sitting on the foot of her bed, and her left hand was clenched in a fist. And we were able to talk to her, but she just wasn't quite there right. But the only neuro deficit we could find, like she was talking, it wasn't slurred, she could move her arms, legs, whatever, but she couldn't unclench that hand. And that was the only actual neuro deficit she had, besides the fact that she was, half undressed, not caring about her modesty, that type of thing, where that's just weird. But the only actual neuro deficit was a clenched hand. Seizures, again, anything cuts off blood supply or injures the brain can cause seizures. Headache, a real stiff neck. I had another lady who was an elderly lady. She had, again, the plaque in the carotid arteries. And she would go to the same hairstylist dresser like once a month and get her perms or whatever. Well, part of that process is they have those fancy chairs where you lean back your head in the sink and they shampoo your hair for 5 minutes and wash it real good and give you the head massage. And a lot of people close their eyes and relax and it's warm water and whatever. Well, her carotid arteries were so unflexible that cut off blood supply. She had a massive stroke and died right there getting her shampoo. Okay? So you never know. Which I think that's a great way to go. I mean, on my list of well, it's a bad hair day, but I mean, as far as
doing your hair for you?
yeah, I mean, you're getting a scalp massage and warm water, and it's a great day. I'm feeling happy getting my hair done. I'm just going to take a nap. Could be a lot worse, huh? Could be a lot worse. However, the hairdresser, when she tries to wake you up, that's a bad day. Okay? All right. Transient ischemic attacks. So what we call TIAs, or little strokes, or mini strokes, a lot of people call them, produce deficits that resolve completely in less than 24 hours. Frequently, these precede a stroke. Basically what this is this is a stroke, usually a thrombotic stroke, that clears itself. Okay? And it can look exactly like a stroke, but basically the body, for whatever reason, is able to fix the problem. So the clot gets broken down, or it gets pushed through, or whatever it is, and they return to normal. It doesn't mean that they didn't have a stroke, it just means that they didn't have lasting deficits. So deficits that return to normal on their own without treatment or intervention within 24 hours is a TIA. Again, if you have a TIA, then the likelihood of having a real stroke is obviously increased. Management of CVA-TIA, we're going to treat them the same. Okay, there's no difference for us. Assess ABCs, protect the airway, high flow O2, vital signs every 5 to 10 minutes. Note increased blood pressure, irregular pulse. So if you are having a stroke, it should increase your blood pressure, because your brain's going to try to force blood to that injured area. So it's going to tell your body, hey, I need more blood, I need more blood. And that can cause irregular pulse. Essentially, you're going to start heading towards ICP. Okay? Management, nothing by mouth, avoid rough handling, transport them paralyzed side down. Again, injured side down, right? You're getting used to that theme. Guard your conversation. Again, they may know what's going on. They may be able to hear you even though they can't see you. Patients who cannot speak may still understand. CVAs caused by thrombus, embolus may be reversible with what we call thrombolytics, clot busters. So early recognition, rapid transport to the appropriate facility is critical. So you need to take them to a stroke center, a primary stroke center. We have what we call primary stroke centers and comprehensive stroke centers. Primary stroke centers if the stroke, early recognition within the first 3 hours. And what they do is they do a head CT. If the head CT does not show bleeding, then they'll consider thrombolytics. If it shows any sort of bleed, then they'll transfer them to a comprehensive stroke center where they'll have a neurologist consult. And then remember in trauma where we talked about epidural bleeds and subdural and subarachnoid and all those, depending on the level of where the bleed is, how much blood there is, what the pressure is, they'll decide whether they need to do surgery or just wait on it or what to do. Okay, questions about altered mental status? What's my favorite mnemonic? Okay. Good deal. I expect you all to memorize that. And if it helps you guys, as you saw I did, I added environment, those different things. If there's something that makes sense to you to add on there to think about, then do it. Mine obviously, when I learned it, it was AEIU. It's the same one you're looking at. But you get to a point where, because of calls that I've ran, I say, hey, you need to think about this too. And that's where I've kind of penciled in those of, hey, I don't know why they don't have environmental on here, because we run that all the time.